Hi. So we're thrilled that this room is so full, and I know that you are not all here to hear about how poorly we've all done with pelvic pain over the last few decades. And so my part of the talk is not data-driven. My part of the talk is how-to. It's a sort of a paradigm opener on what can cause pelvic pain. Certainly, organ-based causes of pelvic pain can be identified. They're not often in isolation, but we can approach multiple different organs that are involved all at the same time. And we always have to think, if treatment for IC isn't working, what else could it be? So I have no industry disclosures, and the objectives of this talk are to go through the differential diagnosis of pelvic pain, initial management strategies, and then toward the end of the session, I'll talk a little bit about setting up a referral network and some actual tools to use with patients. There are resources out there for all of us. Earlier in my career, I worked really hard to learn about pelvic pain because I found the patients challenging. The AUA guidelines discuss treatment for IC. The European Association of Urology has a nice, this is an ICS document on standard terminology for chronic pelvic pain, but it doesn't really give us how-tos on treatment. The EAU has guidelines on chronic pelvic pain that are actually, there are two renditions, 2012 and 2016, and the 2012 version is more of an organ-based document. This document is, I don't think this is very well known, but it talks about the differential diagnosis of chronic female pelvic pain. And this I found to be quite a resource in just opening up my mind as to what could be causing pain. So the urological differential includes bladder pain, interstitial cystitis, urethral diverticulum, but also you really have to consider pelvic floor dystonia as a urologic differential because it's so often participating in your pelvic pain symptoms for your patient. So I've learned a lot from my physiotherapist, both locally and at the ICS, on how to approach chronic pelvic pain. And it's really important to understand that patients will need down training of the pelvic floor. I think probably everyone in this room understands that. But locally, this is not always obvious. And sometimes patients can go to a physical therapist and they'll be focusing on Kegel exercises, and that can worsen or not resolve the pelvic pain. The ICS does have wonderful member resources on finding skilled physiotherapists in your area, and I know that our committees are very helpful whenever I need to refer a patient. Urethral diverticulum. This can be a source of pelvic pain. You'll often see post-void dribbling, pyuria, dyspareunia, and there can be a cystic pelvic exam. You can express fluid and pus. I really only perform an MRI on patients looking for urethral diverticulum as a source of pain when there are recurrent UTIs or post-void dribbling or a palpable mass. A ureteric stone, I personally have had one of these, and the symptoms can be pretty impressive. When the stone is caught in the intramural ureter, then it can actually be a source of chronic pelvic pain. So I've probably had 5 patients over the years whom we cured of their pelvic pain altogether by finding this particular diagnosis. When a patient has chronic bladder symptoms and bladder pain, it is important at some point to do a cystoscopy and rule out other causes of pelvic pain. So obviously CIS or a bladder neoplasm would be something that you don't wish to miss. So interstitial cystitis, Chris has talked a bit about this. Recently I had a male patient who underwent a TURP, which helped him for 8 months, and then his bladder pain and penile burning came back. And we reevaluated him for obstruction, which was not present. There was no bladder neck contracture. And it turns out that at the time of his procedure, he'd had fulguration of ulceration within the bladder. And a hydrodissension as a result of the height of the fluid, and so we repeated that, and he improved. So these patients do exist, but certainly this can be a hammer, and everything looks like a nail when we approach all patients as interstitial cystitis. The American Urological Association has a pretty good guideline on treatment of IC, and I tend to use manual physical therapy techniques as first-line treatments. I also tend to employ the anticholinergics within this strategy, and sometimes it really doesn't matter to me whether the patient actually has IC or not. I'm going to approach the symptoms with the same interventions. Fourth-line treatment for IC includes Botox. It's very important in these patients, especially if urethral pain is a component, that urinary retention is carefully advised and that the patient is able to perform and tolerate self-catheterization if necessary. Sacral neuromodulation is not in the United States FDA approved for pain, but certainly we do sneak it in as a treatment with some success. And cystectomy is something that should only ever be employed after all other measures have been attempted, and the patient should still be counseled that the cystectomy may not resolve the pain. It does help more in patients with ulcerative IC, and it also, when the patient's diverted, I would strongly recommend performing a cystectomy at that time because of the incidence of pyocystis and continued pain in patients who are simply diverted. However, we need to consider the whole differential because pelvic pain is caused by not just urologic issues. The differential is broad, and pelvic pain is often multifactorial. So even if there is a urologic diagnosis, for example, a patient with a urethral diverticulum may very well have reactive pelvic floor dystonia, and so if I don't send her to my colleagues in physical therapy, my surgery will not improve her. So vulvar exposures, it's important to look at what kind of toilet papers the patient is using, whether they're using sanitary wipes, deodorants, soaps, are they wearing lace, are they exposed to spermicidal lubricants, are their lubricants irritating? And so we've compiled a fairly comprehensive list of what's irritating to the vulva and what's helpful to the vulva. That's a pretty simple intervention, and it can be profound. Certainly in the ICS, we have to worry about female genital mutilation and neuromas, as well as stenosis as causes of pelvic pain and dyspareunia. There are centers around the world in which there's a great deal of experience in addressing complications from female genital mutilation and cutting, and there is actually a workshop at the ICS this year on that very topic. Treatment of vulvodynia is more than just the vulva and irritants, so obviously infection needs to be looked for. Vaginal atrophy, I think I've helped more women with vaginal estrogen cream alone than any other intervention I've used in my career. Again, pelvic floor physical therapy can help with even the vulvar pain due to restrictions deeper inside. Oral medications, dietary changes, Botox to the vulva, I've used with success on patients. Some interventional pain techniques through the help of my colleagues, and I've never needed to recommend a patient for a vestibulectomy, although there may be audience members with more experience in this direction. Other gynecologic etiology of chronic pelvic pain includes ovarian cysts, ovarian remnant syndrome, and other adnexal pathologies. Uterine pathologies such as endometriosis, even a uterine fibroid can cause pain, adenomyosis, and in the setting of pregnancy, pelvic girdle pain is more of a ligamentous cause of pain. Colovesical etiology for pain can include, of course, the levator ani syndrome and obstructed defecation. And then there's a variant called proctalgia fugax, which is a situation in which the patient has severe episodic rectal pain, which is more of a levator ani spasm than a continuous hypertonia. Fissures, hemorrhoids, tumor should always be considered. Diverticulitis if it's chronic, and of course constipation. So here's just a picture of a colovesical fistula, which typically you would see recurrent UTIs, but not always. Diverticulitis, the pain is usually in the left lower quadrant, and it can be constant and present for several days. It's not too common to see this for beyond 3 months, but it is possible. And 10 to 15% of these patients present with urinary urgency, frequency, or dysuria due to inflammation from the bladder. Pelvic venous congestion syndrome. In my country, it's difficult to get insurance companies to pay for treatment of this because the data is scarce. However, we've all seen patients in which the patient will have dilated pelvic varices and retrograde flow being weak in the ovarian vein. The symptoms are dull, throbbing, achy pain in the vulva, and the patients become worse over the course of the day. And on physical exam, you can see hemorrhoids, varicosities in the vulva, buttocks, or lower extremities. And on physical exam, it's common to see ovarian point tenderness on examination, and the patient may report a history of postcoital aching. Variants on this theme include the trouble with the pelvic venous congestion is more trouble with the valves in the ovarian vein, but you can also have external venous compression, such as nutcracker syndrome, which is pictured here, and that is compression of the left renal vein between the aorta and the SMA, or May-Turner syndrome, which is compression of the left iliac vein by the iliac artery. So neuromusculoskeletal pain, this can include, again, high levator tone or high tone iliopsoas muscle that can mimic renal colic from a stone, and it can be identified on physical exam. Trauma to the bony pelvis, upper motor neuron syndromes, and lower motor neuron syndromes. So this patient came to me. She was a young mother, probably 21, and she was viewed as histrionic after her delivery, probably due to her age and her anxiety over the early pregnancy. And indeed, she had actually encountered pubic diastasis. She had suprapubic pain, tenderness, swelling, and edema. It radiated to her legs, hips, and back. And it was worse with weight bearing. She was sent home with a walker from the hospital, but there was no diagnosis. On physical exam, a pain can be evoked by bilateral pressure on the trochanters, hip flexion with the legs in extension, and on X-ray, if there's separation of more than 10 to 13 millimeters, that is suggestive of the diagnosis. This is another diagnosis I've seen probably 5 times in my career. This is typically seen in young female athletes, and the idea is that there's irritation of the ligamental tissues along the pubic symphysis, and they can even end up with osteomyelitis, presumably due to hematogenous spread of bacteria to the inflamed tissue. And the diagnosis is made by painful isometric adductor contraction as pictured. And also, they're more likely to have tenderness overlying the pubic bone on exam. Ergonomics. This is a patient who has chronic paraplegia. Her body habitus is difficult, and she spends all of her time lying on her back. And she has had an ileovesicostomy, where the ileum is used to divert the urine away from a small contracted bladder, and she gained a lot of weight after the ileovesicostomy, so it doesn't empty very well. So there have been all sorts of manipulations to the system in order to help with her pain. She's not a great surgical candidate, but she complained of chronic pain. She doesn't perceive pain perfectly because she has incomplete paraplegia. But on X-ray, I just looked at her old X-rays. She spends all of her time on her back, and look at the shape of her coccyx. So I sent her back to her pain management specialist, and he injected the area, and she had 50% improvement. So we were focused on that bladder with the reconstructed system that wasn't emptying well, and really it was her coccyx that was causing pain. We also repositioned her with the help of her aids. The innervation of the pelvis is very complicated. Here you see the superior hypogastric plexus, the hypogastric nerve, the inferior hypogastric plexus, and we have a lot of potential for injury when we're operating in the pelvis. So the somatic innervation of the pelvis includes the femoral nerve, lumbosacral nerve, obturator, sciatic, and the pudendal. A lot of us just think about pudendal neuropathy as the intrapelvic neuropathy, but it's much more complex than that. The autonomic nerves include the hypogastric nerve, which can be injured during pelvic dissection, as well as abdominal sacrocolpopexy. The genitofemoral nerve provides sensory innervation of the inguinal fold, and it can be injured during pelvic lymphadenectomy. The obturator nerve, likewise, can be injured during pelvic lymphadenectomy, for example, a radical prostatectomy. And of course, we all know where the pudendal nerve is, and it can be injured during a sacrospinous ligament suspension or during pregnancy and delivery. Cauda equina syndrome, we often think of this as its presentation as a medical emergency where there's a herniated disc and there's loss of bowel and bladder function, urinary retention, saddle anesthesia, but it can be slower and more subtle than this, and it can lead to chronic pelvic pain. At some point, it is worth doing a lower spine MRI in your patients when they're not responding as expected from the standard measures, especially if your neurological exam is suggestive of loss of sensation. This patient was treated by a urologist for 15 years, Jeanette, and he was treated for prostate and bladder causes of his pelvic pain. By the time he got to me, he had bowel and bladder incontinence. That's actually a condom catheter he's wearing. He had, He had loss of his gluteal bulk, and he also had he had calf atrophy bilaterally, and he ended up having a slow-growing sacral tumor, which chordoma, which was resected with resolution of his pain, actually, and stabilization of the urinary findings. So adult tethered cord is another diagnosis I see with regularity, and it can go undiagnosed until adulthood. The patients can have pain in the low back, legs, and perineum. They can have muscle weakness and numbness in the lower extremities, loss of sensation, urinary incontinence, bowel and sexual dysfunction. And the picture can be mixed from upper motor and lower motor neuron syndromes because with the tethered cord, there's stretching of the spinal cord cephalad to the point of tethering. Tarlov cysts, if anyone in the room knows how to treat these patients, we would like you to come up and speak. These are extremely difficult to determine whether they're simply an incidental finding or whether they're causing the pain. And intervention by cyst aspiration or surgery really has not been shown to be successful in the general literature. This is one I saw for the first time this year. This young lady presented with urethral pain, and she was found to have something called Sherman's disease, which is sort of a kyphosis variant that one sees in the lumbar spine in teenagers. Peripheral pelvic nerve entrapment. This is compression of a single nerve or nerve root. Symptoms can include pain, tingling, numbness, and muscle weakness on the affected nerve's dermatome. And this can occur secondary to endometriosis, fibrosis, grafts, sutures, vascular or muscle entrapment, as well as transection. And whereas most of us think about the pudendal nerve, and certainly for the reconstructive surgeons in the room, this can be important with the sacrospinous ligament vault suspension. The pelvic nerve entrapment can extend significantly beyond the pudendal nerve. So any of the following nerves can cause pain in the pelvis, even though these nerves are deriving from the lumbar levels. So the iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, lateral femoral cutaneous nerve, and obturator nerve. And the way that I do the physical exam, when I see these patients where I'm suspecting nerve entrapment, is I actually pull up this photo before I go into the room to do the exam, and I map out where I think the affected dermatome is and use that to help me identify which nerve it might be. And then so you'll see here the ilioinguinal nerve here, the perineal nerve here, and then you can also map out your dermatomes on the other side of this picture. And then I'll send the patient to our interventional pain specialist for further evaluation. So those are some organ-based ideas about what can cause pelvic pain. It's always important when you hear the history to give the patient the space to tell the story. I really start with a long story that I don't interrupt because I get all those clues. Well, I had this surgery, and after that point, blah, blah, blah. When I have refractory cases who don't respond to the initial mix of interventions we prescribe for them, then we start thinking about more of a systemic issue, central sensitization, small fiber polyneuropathy, which we'll be talking about later in the talk. And if you think about the fact that if a patient presents to you with pelvic pain and bladder pain, and they also have IBS, migraine, fibromyalgia, TMJ, and dizziness, that's a systemic disease. Those things don't all arise in a 30-year-old separately. They have to be linked. And so I'll certainly address the local factors, but then I'm really thinking more on a global level as well. And our patients with pain, they have magnifiers on top of the pain, and it's really important to think about the whole picture and not just the organ. In essence, pelvic pain can be effectively helped, and caring for the patients can be straightforward, especially if you're thinking about the whole picture. And I actually cope in my daily practice significantly by involving my colleagues in multi-specialty care, which ends up leading to a better outcome for the patient and an easier experience for me in managing these patients. Thank you.